All right, so let's talk about clinical methods. Ooh. Um, like I said, there are a lot of things that are similar between research methods and clinical methods. And here are some of the things that are, I want to highlight some differences and I want to highlight some similarities as well. One thing that is true about your education here at ASU is that you're going to have another class on clinical methods. In fact, you're going to have multiple classes on clinical methods. Um, so you might not take another class on research. Not that this was a full class on research methods, but you might not take another class on research methods. So if it seems like we're prioritizing one over the other, that's why. So we want to talk about the intervention process. The first thing that you want to do is identify the problem. What is the very basic problem? Now, I don't mean this person stutters. That's too specific. I actually mean what is the very basic problem. That there is repetitions or prolongations or blockages, things like that. I'm going to talk about the actual symptoms. Maybe you could say that there are distortions of this sound, and now we're not talking about necessarily stuttering, but there's distortions of this sound and omissions of this other sound, right? So these are the kind you want to identify the problem that way. You want to write, what do you know about the problem? When does that occur? When does that show up? Is it persistent? Does it only happen when they're tired? And then you want to formulate a hypothesis for a solution. You know, somewhere in here, somewhere between those two, within one of those two, you want to maybe take a stab at what the diagnosis might actually be. This seems like stuttering, or this seems like a speech delay, but a typical progression, but a delay, right? Or maybe you could even say like there is a structural problem with this child, and that's where this distortion comes from. So then you want to make changes to variables. Maybe you want to have them try to use their tongue differently if there's a structural problem until they can get some form of surgery to correct the structural problem. Maybe if it's stuttering, you want to have them try to slow down and calm down and plan ahead what they want to say. One other thing that I totally forgot to mention when we were talking about stuttering is that one good intervention to make is to have people that stutter tell a conversational partner, if it's a new conversational partner, that I stutter, right? So you'll say, well, I stutter. And so then it kind of takes the weight off of the person who stutters, the person who's talking, because, or a little bit of it anyway, because then the other person knows. They know to expect that there might be a stutter, and they know to just ignore it. If they don't tell them, then the person who stutters might, be really self-conscious about the stuttering, and then they'll end up stuttering, and then the person is like, what is going on? Where they wouldn't think what is going on if they had said like, I stutter ahead of time, and then the person won't even think that probably. So anyway, sorry for that aside. So one thing you want to do is formulate a hypothesis. This looks like stuttering. You want to make changes to variables. So you want to go through different kinds of interventions. You want to collect data. So you want to look at how much do you stutter now that we've made this change to this variable. You want to analyze the findings. You want to see, like, is this a significant change? And you want to formulate a conclusion based on that hypothesis, right? So, like, yeah, it looks like there has been a reduction in stuttering based on what we've done. So we're going to keep doing it and see if it continues to progress. Or, alternatively, no, there hasn't been this hasn't helped, so we might try it for another week, and then we're going to think about doing something else, and then you go back to the top. So this is a cycle, just like the research cycle. And in fact, most of these things you can probably see parallel what we do in science, right? Identifying the problem, the very specific aspects of the problem. This is like doing a literature search. This is doing your background research. What do you know about it? Formulate a hypothesis. This is your research question or your also hypothesis. You want to make changes to the variables. So this is like identifying the variables and doing the experiment in research. You want to collect data. Well, it's exactly the same thing in both of them. You want to analyze your findings. Again, same thing in both of them. Then you want to formulate a conclusion based on that data. Same thing in both. And then you go back to the top. It's the same process, really. You're just applying it to a different domain. What? Why does it always do this to me? There we go. So let's take a look at this guy, and we'll follow along with this intervention process. So Billy's a kindergartner who does well in school, but when he gets excited or upset about something, he has a hard time getting his words out. He gets stuck or repeats words, and his teacher is concerned because she is noticing it during times he's relaxed, too. There should be a comma after relaxed. Sorry about that. So let's identify the problem. What is the problem? Well, he gets stuck and he repeats words. Interesting. You probably are already thinking, this sounds like something that we've talked about a lot. What do we know about the problem? Well, it sounds like stuttering. We need to give him an assessment to see if the stuttering is bad enough to qualify for therapy. Remember, some stuttering is as bad as 1 in 5 words, and that's some of the worst. So there's even, lower rates of stuttering that would qualify for some types of therapy. So again, identifying the problem. This is like doing your literature search. You're looking at what the specifics are. This sounds like stuttering. This is kind of generating. This and the next one are sort of like generating a hypothesis, right? So you're like, this sounds like stuttering. We're going to give an assessment. We think that this certain type of therapy, one that you choose based on other things you know about Billy, can give him strategies to speak fluently. And then you're going to make the changes. You're going to implement the thing. If this was research, this is when you're actually doing the research. Here, you're implementing the treatment procedure. So you're teaching strategies for smooth and easy speech. You're going to collect data, and analyze it. So you're going to look at rates of disfluencies. Remember we talked about you're going to look at the percentage of disfluencies per speech sound. You're going to look at the percentage of stuttering-like disfluencies to regular disfluencies. These are the kind of data that you're collecting. If you're looking at something else, if you're looking at omissions, you're going to look at number of omissions per speech sound. You're going to look at number of distortions per speech sound, things like that. All of the measures that we've been talking about, this is the data that you're collecting. And what you're hoping to see is that there's a reduction. When there's not a reduction, then you're going to have to change it. I mean, in this case, the therapy is helping him speak more fluently because we see that there's a reduction in disfluencies, but maybe there's not. And in that case, you jump back to step 3, and you come up with a different therapy. You tried it for a couple weeks, a month, and there's no change. Maybe it's time to try something else. Now, that is one area where clinical and research methods differ. Clinical methods are adaptive. They're dynamic. You can change them when you see that something isn't working. Your goal in clinical methods is for your client. You want your client to progress. Your goal in science is to learn something. So if you notice that your participants aren't progressing with the treatment that you've decided to test, you don't change the treatment in the middle of a research project. You keep the treatment exactly the same in the middle of a research project. Because what you're doing is, there's two different methods of focus, right? So in clinical methods, you are focused on where's my hand? There we go. You're focused on the person. You're focused on your client. In research, you're focused on the research. So here in clinical methods, I should do this bigger. The research encompasses more participants. Okay, so in clinical methods, your responsibility is to your client. With research, your responsibility is to science. And usually those things are in alignment. It's rare that they're not. But in this one case of being able to change things, that's when they're not. You want to follow through with your scientific study in the way that you've set it out, because if the new treatment that you've come up with doesn't work, you need to tell everybody it doesn't work. You have to follow through with something that doesn't work until the end to prove that it doesn't work. And then you can publish a paper on it, tell your colleagues, don't even go down this road. This is like a fool's errand. It doesn't work. And you're helping more people by telling them not to do this. Clinical methods, again, your responsibilities to the client. So you're going to try something. If it doesn't work, there's no reason to continue with this treatment if you've gone enough time that you should be seeing a result and you're not. Change it. Your concern is for that person to progress. So that's the one area where they're different. It's not really that they're at odds. It's that their responsibility is to two different things at that point. However, we're going to see more similarities. So the intervention must be evidence-based. You can't just pull something out of your ass and say that this is going to work. Oh, I probably shouldn't have said that. Whoops. You just pull something out of your head and say that it's going to work. It needs to be something that's evidence-based, right? So you're going to go to the research and you're going to find something that's evidence-based and you're going to pull it out and you're going to try that. And then when you're doing research, you're coming up with new treatment methods that will be the evidence that someone else will pull from. You're going to consider individual abilities and needs. So let's say that this person seems to have little to no anxiety. Even when talking with authority figures. Remember, we know that stuttering gets a little bit worse when you're talking with authority figures. Maybe we see that Billy doesn't actually get worse when talking to authority figures, not when anxious or anything like that. And so it's still stuttering, definitely. It just doesn't happen that it gets worse for them when they're, talking to authority figures. So the relaxing methods might not be the thing they need. Maybe we need to focus more on that basal ganglia stuff and speaking with an external tempo, or somehow taking out the action perception loop, because there might be something disordered there. So that's the kind of thing we need to focus on, the individual abilities and needs. Man, I cannot talk today. And then again, we want to follow a systematic progression, but this is what we talked about. We have the research cycle. We have the clinical cycle. We have specific steps that we have to follow to make sure that things are done right. You begin with a diagnosis. You select therapy targets. You go through the training procedures, and then you can complete it when the mastery of the behavior is achieved. It gets a little bit more involved than that, because what you want to do is you want to choose a goal that is attainable. So it's kind of a, not a very far off goal, and then maybe another goal that's a little bit more far off. So the next time that you assess, you can say we completed this goal, and now we're going to come up with a new goal. Maybe our goal that was a little bit further off becomes our close goal, and we set a new goal that's a little bit further off. And so we keep up this cycle. And that's good because both you and your client can then see that there's some progress being made. And this is going to jump back into psychology, but when you see that progress is being made, you buy into the therapy a little bit more. And sometimes the therapy can work better just by you thinking that it's going to work better. There's a little bit of a placebo effect in all treatments. A little bit. That doesn't mean that all treatments are not real. I'm just saying that the placebo effect is there whether the treatment is real or not. So if you've bought into it, or your clients bought into it, there's going to be some gains made just by that fact alone, in addition to what you gain from the treatment. So you want them to see that they're making some sort of progress. Okay, so let's take a look again at Billy. So we're going to begin with a diagnosis. Testing with our standardized, tests that we find for stuttering. We're going to observing Billy in other settings as well shows that he has a moderate stutter. We're going to set some therapy targets. By the next IEP date, Billy will identify and describe 6 fluency strategies with 80% accuracy. Given minimal cues in 4 out of 5 sessions as measured by SLP data collection. By the next IEP date, Billy will use fluency strategies to produce fluent speech in 9 out of 10 opportunities, given minimal cues, in 4 out of 5 sessions. So you see, we've gone from 80% to 90% as measured by SLP data collection. We want to give training procedures and implement them. Easy speech is taught during therapy sessions. So easy speech just means, like relax, like make sure you're not tight, your throat's relaxed, your jaw's relaxed, you're not going to get into any stuttering there. And then when Billy meets the goals by the end of the IEP term, we'll choose new goals. Or in the event that that's the last goal that needs to be achieved, Billy gets to graduate from being in therapy at all, which is a great time. All right. So there's also a couple of universal design principles that we should look at. These are usually abbreviated UDL, Universal Design Principles for Learning. And this is a little bit like it's related to our research ethics. It's related to our ASHA ethics that we've gone over, both of those. Every individual is entitled to universal access to information and learning. And that means that they have to have multiple means of representation, expression, and ability to engage with their therapy, with their caregiver, with their peers, everybody's different means to engage. And that means that you have to be flexible in how you're interacting and how you're delivering your your therapy, basically. Different people will need different accommodations, right? So it sounds like Billy is standard. There's not a whole lot of accommodations that need to be made. You can probably just work with him in a typical room without anything extra. But sometimes there needs to be AAC devices. You've recently seen a lecture on AAC devices, and these are the kinds of things we have to provide to be able to again the words leave my mind. This is why I don't use notes for these things. I usually just have it in my head, but it would be better. Well, let's just say accurately then. To be able to accurately help our clients, you need to have these things ready or be able to get them, different methods of instruction and communication between you. Okay, so we talked about writing, but we're going to talk about writing again. No, sorry. Clinical report writing is huge, right? Just like in research, writing, it's sort of like reports there as well. Writing articles is huge. So what you want to do is you want to summarize and interpret everything that's gone on. You want to summarize and interpret where your client is, their skills, their abilities, what they still struggle with. You want to report their test scores and performance data. So you need to learn how to write scores and data and tests and things like that. You want to explain each data point. So don't just say that they got 9 out of 10. Give context. Because these are read by not just your like the head of the SLP department or something like that, or the special ed department. They're also read by the student's teacher. They need to know what the heck you're talking about. So all the things that we've learned in here, the very specific things that we've learned that we need to know, they learn all sorts of different things. So you have to be able to tell them like 70% sounds like a C when you're grading it, like you're a teacher. 70% on a test sounds bad. But in our world, 70% on this test is actually good. It shows, that we're really close to moving on to about 90. So maybe this is good. So provide some sort of context for these data points you're getting. They're also going to the parents, who you would expect have even less experience with these things than the teachers do. You also want to report what the client still needs, right? So like where are we progressing? What does it look like we're going to need? There's this other problem has cropped up, stuff like that, right? So you really want to give like a comprehensive picture of your client. I know we're focusing on kids, but this is also true if you're at a hospital. You want to talk about your patient. If we're at an external care facility for older folks, you want to be able to talk about, and you're still communicating with the family, you're still communicating with doctors and other people who might not know all of the things that you're talking about that way anyway. So if you're talking to, like, let's say, a general practitioner or a brain surgeon, and you've got somebody who's had TBI and they've generated stuttering somehow, you need to explain to them all these data points. Yeah, sure. I mean, it seems like they're much more highly skilled in an area than, say, some kid's parent. We don't necessarily know that for sure. The parent could be a brain surgeon for all we know anyway. But they're not specialists in your area. So you have to be able to convey it to them as well. Here's some tips, but I gave you a different thing of tips. These are taken from a different something else. These are good too, though. Right in third person. I think most of these are covered already, so we'll skip this. Here's a sample report. I'll let you look at this. You have the slides. I'll let you look at this. And then there's a few different legal responsibilities. So all children have the right to have access to free, appropriate, and public education. This is something you'll hear a lot, FAPE, free, appropriate, and public education. When this was passed, this, really blew up the special ed field. So if you're an SLP who's working in SPED in classrooms, you're going to be dealing with this a lot. This goes from 3 to 21. It is here. So children from 3 to 21 are going to be getting education from the school, potentially from you. So there's a lot of clients that you'll potentially be dealing with. Also, another one. These are all important, but HIPAA, there we go, is another one that you're going to come in contact with in schools, in hospitals also. This is a protection for your patient's records, so you have to comply with these as well. This is something that we don't actually really have to deal with, either of these, in research. So that's one other difference. We have to comply with the internal review board and our ethics codes and all sorts of things like that. So we've got our own red tape, but it's a little bit different. And then here's a couple employment opportunities when you graduate. When you have a BA or a BS, Bachelor's of Science, I forgot what the A is. Like, everybody's getting a BS. Oh, Arts. Bachelor of Arts or Science. So you can go and get your SLPA certification. A lot of people, some of the people from this class have already asked me about doing that. If you want to work as an SLPA while you're, doing your classes to become an SLP, it's a good way to get some experience on your resume. Scribes, developmental specialists, other things like this. All right, so that is it for this slide. Let me jump back. Okay, to right here. So, just to summarize, there's a lot of similarities, right, between research methods and clinical methods. One of the main similarities is the cyclical nature. The other similarity is that you're collecting data all the time. You're forming a hypothesis, you're collecting data, it's all evidence-based. You never just come up with a study and you don't have prior evidence to base it on. Maybe the first research study that was ever done had that, but we're so far beyond that there's always going to be something that you can cite to help guide you. And that's true here too. And then again, another major difference between the two is your focus, right? So in research, you're focused on the research. You need to have research integrity. So if you notice that something isn't working that you thought was working, you got to push through to be able to report that it didn't work. In a clinical setting, if something isn't working, you change. You change until you find something that's actually helping your client. Okay, that is the end, and I will see you next week. We're going to talk about a lot of hearing things next week. It's all hearing all the time.